So welcome everyone to ID at Home, a virtual conference meant to bring patients, caregivers, clinicians, and researchers together to discuss the challenges and lessons learned throughout the COVID-19 pandemic to help inform the way we conduct patient-centered research for infectious diseases in the future. My name is Joey Mattingly. I'm a pharmacist and health economist here at the University of Maryland School of Pharmacy and a faculty member with the Patients program. This is a team that partners directly with patients and care providers to answer research questions about the best treatment options to improve health and quality of life. I'd also like to introduce my collaborator on this project, Dr. Eleanor Wilson. Dr. Wilson's an associate professor with the Institute of Human Virology, where her research focuses on improving the health of patients with chronic viral infections, as well as advanced liver diseases. All right, Dr. Wilson, are you ready for today? I guess I'll say Eleanor for today. How about that?
Yeah, thanks so much, Joey, and welcome everybody. Thank you so much for joining our conference. Really looking forward to the discussion we're going to have today.
Awesome. And again, we want to thank everyone for attending today's event. When Eleanor and I began brainstorming in the middle of the pandemic about an idea like this, we just talked about how academic conferences, we feel like do a great job of bringing researchers together to network and learn from one another. And we wanted to try to replicate that, especially the shared learning component, the engagement, and encouraging scientific collaboration that we know will be needed to tackle all those post-pandemic challenges that we may have. So that's sort of where this event came from. So for today, just a real brief overview. So we're starting with we're going to have 3 individual speakers that I'll introduce in just a moment. And we've built in little 15-minute breaks to kind of give us a little bit of cushion if we go a little long or a little short. And again, because it's a virtual conference, attendees, you're more, like I said, your cameras aren't turned on. So if you need to jump up, take a break, come back, this is totally meant to be flexible. Okay. So we'll do our individual speakers at first, then we'll bring those speakers back together to do a moderated panel. And then we'll have a special guest around 12:45 that'll jump on, actually 2 special guests that'll come on and provide a few remarks. Then at 1 o'clock, we'll switch over to the second topic and we'll follow that same format where we have our individual speakers first, and then Eleanor will moderate the second panel. And then just a reminder, we'll send out a post-conference survey to get your feedback. We'd love to hear from you how, since this is our first time doing this, we'd love to hear from you on how we can improve it to make it better for next year. Now, before we begin our programming, it's really important to acknowledge our primary sponsor, the Patient-Centered Outcomes Research Institute, or PCORI. We also like to thank all of our colleagues at the University of Maryland Schools of Medicine and Pharmacy, as well as the teams at the Institute of Human Virology and the Patients program for all their support to make this event happen. So before we begin, I'm going to test out the poll function here in Zoom, okay? So I've set up a couple polls beforehand. And so would love to hear from you. So let me see if folks can see it. I launched the poll. Would like to just kind of get feedback from you on whether or not, or which stakeholder group you represent today. Now, some of you may represent more than one. So, you may be a physician, but also you're a patient yourself or a caregiver yourself. So you might even represent more than one. But who might, what would be your primary community be? And then this also will help us kind of understand what our audience looks like. Yeah, so primarily the research community, like we were expecting. I can share the results. So yeah, we primarily a research community, but we have kind of a broad community. We have some clinicians, patient community members, as well as payers, and a few others. So for session 1, we're going to be talking about virtual remote engagement lessons learned during the pandemic. And so for this topic, we've got 3 very special guests. We have Karl Cooper, Ivey Wholfeld, and Erin McCreary. So first, Karl Cooper is an attorney and disability advocate. As a person with his own disabilities, he spent most of his professional career addressing the needs of individuals with disabilities. Currently, he serves as the Director of Public Health Programs at the American Association on Health and Disability, or AAHD, where he oversees a number of projects which conduct outreach in the disability community to engage them in public health initiatives. He started at AAHD in 2013, working as the project manager for the National Disability Navigator Resource Collaborative. Prior to moving to Washington, D.C. in 2012, he actually practiced law for 14 years in the greater Philadelphia area, where he was able to devote time to pro bono advocacy for those affected by physical and developmental disabilities. So in addition to his work at AAHD, Karl is the current chair of the Disabilities section of the American Public Health Association. Karl received his law degree from Villanova University School of Law in 1997 and a BA in Communications, Political Science from Cedarville University in 1994. Next, we have Ivey Wholfeld, who's a program manager for the Eugene Washington PCORI Engagement Awards, the program at the Patient-Centered Outcomes Research Institute, or PCORI. She's responsible for decision-making at a high-level management of the program, its funded projects, and activities that advance PCORI's engagement mission. She also provides operational project management and of the administrative functions of the Engagement Awards program, ensuring efficient and effective daily operations. Before PCORI, Wholfeld was a project manager and specialist at the National Association of County and City Health Officials, where she managed several engagement and recognition programs. She also served as a geographic project manager for the Census Bureau, where she provided program development, support, and implementation for the field's division's geographic programs. She received her BA in geography from the George Washington University in Washington, D.C. And last but not least, we have Erin McCreary, who is a clinical assistant professor with the University of Pittsburgh Department of Medicine and an ID pharmacist at the University of Pittsburgh Medical, or UPMC. She's also the director of the Stewardship Innovation for ID Connect. Dr. McCreary is a graduate from Auburn University, the Harrison School of Pharmacy, and completed her PGY1, which her first year program, a postgraduate residency, and her PGY2 in infectious disease residencies at the University of Wisconsin Health. Since joining UPMC as an antimicrobial stewardship and infectious disease pharmacist in 2018, Dr. McCreary has helped advance key initiatives, including beta-lactam dose optimization, antibiotic allergy assessment, and AUC-guided vancomycin pharmacokinetic service. Earlier this year, she received the UPMC Innovation Award. Most recently, Dr. McCreary chairs the UPMC COVID-19 Therapeutics Committee and serves as a co-investigator for the Remap CAP trial, a global adaptive clinical trial that's going to be evaluating multiple therapies for COVID-19. She's become a leading authority on COVID-19 therapeutics, both locally and internationally. She served her profession in numerous roles and most recently appointed to the executive board of the Society of Infectious Disease Pharmacists. And I do got to give another shout out to the SIDP folks for also helping promote our event today. She's been invited to speak at numerous scientific conferences, including this one here that she'll add today, and is definitely a leader in defining the role of social media in medical education. So again, and attesting to her many accomplishments, Dr. McCreary has been nominated for the 2021 American College of Clinical Pharmacy New Clinical Practitioner Award. All right, with that, excited to kind of get this started. So we're gonna start the first session with Karl. So Karl, if you want, do you want to let you share your screen here? Let me make sure you're able to.
And thank you, Joey, for having me speak today. As Joey said, my name is Karl Cooper. I am a attorney originally from Philadelphia, and I've been told I talk very fast on these kind of things, so I will try and watch my speed so that people can follow along with what I'm saying. But just a little bit of background on who we are as an organization. As Joey mentioned, I'm a person with a physical disability myself, and our organization, American Association on Health and Disability, work on serving people with disabilities, specifically with our mission of promoting health and wellness for people with disabilities. That is cross disabilities, so it includes physical disabilities, intellectual disabilities, mental health, developmental disabilities, the whole, all phases of disabilities and all types. It also includes across the lifespan as well, so not just adults with disabilities, but also children with disabilities and older adults with disabilities. So we do this through 5 main objectives that we have as an organization. We work to reduce health disparities. We advocate for community inclusion. We promote full accessibility in healthcare settings. We work to integrate disability into the public health agenda, and we advance knowledge translation and disability research. One of the ways our executive director is fond of saying it is we look for sort of some of those programs that are maybe initiatives that are aimed at improving people's health, and where are people with disabilities falling through the cracks, and trying to make sure that those cracks are filled so that all people are included and people with disabilities can be fully included and integrated into public health and other health and wellness initiatives. If we're going to talk about doing outreach to the disability community and specifically how it's affected in COVID, then we need to know a little bit about the audience. So I do want to take just a brief moment and talk a little bit about the disability community and who they are and sort of what exactly makes up the population. And no surprise, there are significant health disparities for people with disabilities. Now, a common question that I will get, especially as an attorney, when it comes to disability is, well, how do you define disability? And the truth of the matter is, there's no real easy way to define disability. There's multiple ways you can define it. There's multiple ways it's defined in federal statutes. And depending on how you define the term will determine how many people with disabilities exist in this country. So there's all types of, so if you hear different statistics on the number of people with disabilities, it's for good reason. It's because it's depending on how you're defining the term. You'll have, for instance, a federal statute like Social Security disability, which is going to define it very narrowly for good reason, because you only want those who really need those benefits to receive them. But then you'll have other federal statutes like the Americans with Disabilities Act, where you want it to be as broad as possible and help as many people as possible. So that will be an even broader definition. If you hear the term, if you hear the statistic 1 in 4 or 1 in 5 people have a disability, it's that broader definition that people are usually talking about. For purposes of what I'm going to be talking about today with the statistics I'm going to be going over, we're talking about one that's not quite as restrictive as, say, the Social Security disability definition, but is more restricted than, say, the definition under the Americans with Disabilities Act. And in this instance, we're talking about disabilities which seriously limits an individual's activities of daily living. And according to HHS, that comprises about 12.5% of the population, or 1 in 8 people. And for this particular statistic, or for this particular group, I should say, there are some interesting statistics as it relates to their health. People with disabilities are over twice as likely not to see a doctor due to cost. They're over 30% more likely to be obese. They are 60% more likely to smoke. They're over 2.5 times more likely to develop diabetes. So already you can see there's a number of things that are sort of weighted against this particular population. Let's talk about some social determinants of health and how that affects people with disabilities. So people with disabilities have double the unemployment rate among those within the workforce. And that's a key phrase at the end, among those within the workforce. This is not talking about people that are unable to work because of their disability. We're talking about people who have a disability who are active members of the workforce. And the unemployment rate typically is double that of those that do not have disabilities. And that tracks pretty much regardless of what's going on in the economy. So when the economy is doing well, the unemployment rate is still about double. And when it goes, when the economy is not doing well and unemployment rates go up like it did during the pandemic, and you've got, rates around 10%, well, usually then it's going to track around 20% for people with disabilities. So it hits that community that much harder. About 35% are more likely to have less than a high school education. And people with disabilities are also less likely to report sufficient social and emotional support to meet their needs. In terms of disability across the lifespan, I include this, this particular slide for a couple of reasons. Number one, to give credit to all the statistics I just quoted. They come from the article that's referenced on this particular slide at the bottom by Gloria Cron, who was formerly with CDC and as at the, I think at Oregon State or University of Oregon, one of the two, I'm sorry. Wrote this article on persons with disabilities and unrecognized health disparities as a population that's in the American Journal of Public Health. And all the reason I put this particular slide up is to show how disability progresses as people get older. So there are really two different types of populations when you're talking about people with disabilities. You're talking about people that have a disability from birth, like myself, or you'll have people that have acquired their disability earlier in life. And then you'll have people that age into a disability. So there's two distinct populations, those that either are born or acquire disability early in life, or those who age into a disability. And people who age into a disability usually have a much different view of their disability than those that have a disability earlier in life. People that age into a disability are going to be much more, I would say, they're going to accept it as part of the aging process. and not necessarily view and view a loss of independence as a result. Whereas people with disabilities who have had disabilities their whole lives look for ways to try and maintain independence regardless of their disability, and are going to have a different expectation as it relates to what's available to them. And that's going to be very important when we're talking about virtual engagement, because it does become then, one of the most common things that happen to people when they get older and they age into disabilities. They're aging into disabilities that are going to affect sight and hearing. And as a result, they might not have the same expectations as someone that lost their hearing or lost their sight early in life or were born deaf or blind. And as a result, they will not have those same expectations as to what should be provided to them when they are participating in different processes. So it's just something that's important to keep in mind when you're talking about virtual engagement, because it does become a relevant factor in terms of what people expect. And those people that are older, they're going to be like, well, that's just what happens when I get older. I guess I can't participate in these events anymore. Whereas someone that's younger is not going to have that sort of same approach. So let's talk a little bit about accessibility and etiquette, and understanding exactly what that means in the virtual world. As an organization, we do a lot of outreach on accessibility and making sure that things are fully accessible when people are hosting events. And this predates COVID. It's been something that we've done as an organization since we've been around. And this particular slide is a slide that I've used numerous times in various presentations I've done to sort of highlight some of the areas that people need to think about. What is different about the slide now is, for virtual stuff, I've started bolding the last 3 bullet points, because this is really where we're living now. When you're talking about virtual engagement, you're not going to worry about whether your parking lot's accessible or your building or elevator and restrooms and all that kind of stuff are accessible. But you do have to, it does raise a whole nother level of accessibility and how it does interact with the disability community, and making sure that some of these things are available to people so that they can fully participate in these kind of events. So we're talking about alternative formats, which includes Braille, large text, audio formats, and digital formats that are screen readable. Also, packaging and messaging and materials, making sure that they are fully inclusive of people with disabilities, that people with disabilities are represented in those materials, and also specifically talking about how it is, how it's packaged to people so that they know that their needs are going to be met, that they know that there's going to be alternative formats available if they need those, and that they're done in a way that is fully accessible. And I'll talk about that in just a moment. And then finally, font size. For people that have low vision, they usually want larger font sizes on things so that they can see things, and making sure your presentations and the like are done in a way that is fully inclusive. So let's talk about accessibility in a virtual world and what it means. Already said alternative formats for printed materials are needed. And most people immediately think, well, that means Braille, but that's not necessarily what it means, especially in a virtual world. That's not what it means. What it means is having documents that are can interact with a screen reader. You'll hear the term 508 compliance. 508 compliance is basically a way of talking about making sure that all of your online materials can be interacted with an online or a screen reader. A screen reader is what someone with who is blind or low vision uses to interact with their computer. It reads everything to them. Well, if things aren't coded properly and are not set up properly, they are either going to not be able to interact with the document at all, or they're really in a struggle to interact with the document because it's not set up properly. So making sure that that is done correctly. And there are organizations that do that. As an organization, we have someone on staff that sort of has a specialty in this area and just understands exactly what needs to go into that. We also talk about allowing for alternative means of participation. So allowing someone that is participating in an event, allowing them to be able to maybe come in a different way. It might mean, opening up a phone line if you're on something, or it might mean, making sure that other folks, that they have the ability to communicate in ways that maybe are non-traditional. Including alt text and online images. And this goes back to the screen reader. Alt text is basically when there's a photo in on a website or something like that, alt text basically reads a description of what's in the photo to someone who uses a screen reader. Making Zoom accessible. There's a few ways we can do this. Number one, you can add captions, and I'll show you that in a moment, how that can be done. You can also use ASL interpreters who can be part of the panel, and they can be, someone can highlight them if they really need to look at them to be able to see what's going on. So you can have ASL interpreters as part of what you do. And also screen sharing. When you're screen sharing, making sure you're explaining what's on the screen for people who have vision disabilities. And so they understand exactly what it is that they're seeing, and allowing people then to know exactly what it is. And we always say, be flexible. Make sure that you're doing your presentation in a way that's going to allow some flexibility. We had the poll earlier, which is a great thing. And screen readers have been, they've worked with making sure that screen readers can interact with those. But sometimes people want to do something outside of Zoom and put it up on a shared screen. Then it becomes a little more problematic. And how do you do that? And using the chat function as a way to communicate with people, because screen readers do read the what's in the chat function. So it's another way to sort of make people be able to participate fully. And the way you do that is you ask people ahead of time, what do you need to be able to fully engage in this? What accommodations do you require? And letting people know that. If you are interested in doing captions on Zoom, I can tell you a couple quick things you can do. Zoom has really improved its capabilities for its auto-generated captions. And the way you do that is I've highlighted here. If you go into your Zoom settings, there's an advanced setting for closed caption. You have to make sure that it is turned on with this little blue button that's right here. And also that this blue box is checked, enable live transcription, which allows it then to do the automated transcripts. Then when you get into the actual presentation, what will happen is you'll have a live transcript button as the host, and you click that, it gives you options, and you can enable auto transcription for the automated transcript. And they've gotten much better. The AI has gotten a lot better to be able to interact with that. And it also then allows you, if you want to have a captioner participate and actually do it themselves, because they can do it with much more accuracy, you can assign the participant to type and assign the captioner to do it. I would consider that the best practice, as opposed to using the auto transcript, because the auto transcript isn't going to get everything right. They're not going to get acronyms right. It still struggles with the word COVID and things like that. So and also if someone has an accent, sometimes it's a little harder for it to pick up on things. So best practice is to assign a participant to do it and get a captioner ahead of time and pay for that. Couple quick resources, because I know I'm running out of time. Since this is about COVID, I did want to highlight 2 studies that we did. We did a COVID and disability survey at the start of the pandemic. It was a snapshot, sort of where people were, some of the things that they were, lacking in terms of what they needed and the like. You can read about that at the link that's on this slide if you're interested in that. And then also, if you want to, in terms of, we have a COVID-19 vaccine survey that we did earlier this spring. You can go on and read about that. It talks about how people were doing at the time with people with disabilities were doing with vaccines, whether they had been vaccinated, whether they were going to be. And I just have the bar graph that highlights that particular result that we have in there. So I'd encourage you to check those out if you're interested in learning more about that. I am not the researcher that did that, so I can talk about that in a limited capacity, but if people have questions, I can try and help on that. And then finally, if you are looking for more resources on doing things with disability, etiquette, and accessibility, we have an etiquette fact sheet that we had done for our NDNRC project that Joey mentioned when he introduced me. And then also we have several documents that we've done on outreach to people with disabilities. And among them, the one I have there at the top is really a virtual platform accessibility tip sheet, going over a lot of the things I just talked about and sort of what to be thinking about. It's not a document that's going to give you all the answers, but it's going to get you thinking about what you need to think about and giving you the directions on where to go for that. So at this point, that's the end of my presentation. That's my contact information. Feel free to reach out to me via email if you have any questions, and I'll be happy to take any questions later on.
Fantastic. Thank you very much, Karl, and right on time there too as well. All right, so we'll set up and turn over to our next speaker.
All right, wonderful. Well, good afternoon, everyone, and thank you for having me here today to share the UPMC experience with COVID-19 related care. And what I'm really going to focus on is how we invested resources and energy into engagement from providers across our health system, as well as patients. And we are a 40 hospital health system across 3 different states, New York, Pennsylvania, and Maryland. And when we went into the COVID-19 pandemic, we approached all COVID-19 related care with the goals of equity and enhanced access regardless of patients' zip codes. And so the 3 key areas that I'm going to discuss today are: 1, how we built an embedded platform system so that every single patient presenting to any UPMC hospital had the same opportunities to enroll in clinical trials and receive experimental therapies as patients that go to larger academic hospitals. And so pre-pandemic, you could only enroll in a clinical trial if you were at the academic centers, and now with some exceptions, but we wanted every patient with COVID-19 to have the same opportunities. 2, our process for allocating scarce resources throughout the pandemic. And then 3, our very robust monoclonal antibody infrastructure, which we think will serve as a model for rapid implementation of outpatient care for other systems even past the pandemic. So in early March 2020, when this was all kind of coming, really late February, early March, we were all trying to figure out what to do with COVID-19. And I am an IG pharmacist at our main academic hospital. And I emailed our head of infection prevention, who was working on COVID-19, of course, at the time. And I was like, there's a lot of really crazy stuff coming out with pharmacotherapy, and I'm afraid patients are going to get hurt. Quite frankly, I don't know that anything helps these patients at this point, but I don't want them to experience harm. Is anyone working on a guideline or a COVID treatment guideline? And he said, nope, congratulations, you're it. And I was like, well, I'll write a guideline, but we should do this on a system level. I shouldn't just do this for my hospital. Doesn't make sense for multiple pharmacists or multiple physicians to be working on the same content. And so within about a week, we had support from the C-suite to form what we call the System COVID-19 Therapeutics Committee, which I have chaired since March of 2020. And what this committee was a subsection of our Pharmacy and Therapeutics Committee for the whole system. And we were given the ability by leadership to make therapeutic guidelines changes and decisions without going to formal P&T approval. So we removed a lot of the red tape so we could be nimble and adjust accordingly. What we also did at that point in time where we were given resources. And so I think leadership buy-in and resources are going to be key across all of these equations about engagement and access, as well as information technology. And so we integrated very closely with our IT teams, what we call our e-record team. We actually have 5 electronic health records across the UPMC enterprise. We have 7 if you count our outpatient systems as well. And so we needed to do everything 7 different times whenever we made a change. So a lot of IT, and with those resources, we also were able very quickly to what we call lock down almost every medication that was being suggested for COVID-19. We built alerts, we built reports. And so our central teams every day get an email, which has an Excel file of every patient in the hospital, on any of these therapies. And then we used that central team and built local teams that we worked with closely. We had weekly huddles with them. So they were screening their patients and really just ensuring everyone was getting the same kind of care. The last thing that we did is we created what we call a culture of learning while doing. And so we felt pretty strongly that you couldn't ask people to follow guidelines, which largely said don't do anything for these patients, unless you gave them the ability to feel like they were doing something. And we knew we needed to have buy-in from all of our local providers and from patients. And that was essential for engagement on every level. And so we recognized that we are always faced in healthcare with the desire to do something, which is treat the patient. So in the early days, that would be give hydroxychloroquine, versus learn, which is really test these therapies in randomized controlled trials so that we can do the best thing for all subsequent patients. And so we recognize this kind of juxtaposition of the need to do and the need to learn. And we built a system in which those things could happen simultaneously and to get culture and buy-in for that. So let's talk about that clinical trial first. Throughout all of this, we had an expression we adopted that it's not about the drywall. So it's not about where the patient lives. It's not about where the patient's located. It's not about the patient could be in the hallway of an emergency department in a pop-up hospital because of overflow. None of that mattered. All that mattered was their clinical status, and everyone should get the same care based on clinical status. And so, traditionally you'll say, well, you have to be in an ICU to enroll. And we knocked that down pretty quickly, recognizing it was about the patient at the patient level and not about, their location. And so to make this learning while doing culture, you have to get every prescriber and every patient to buy in. And again, the way you do that is you give them the option to do something, even when they're choosing that option to do something. And that actually leads to them doing nothing, which would be enrolling in a trial where they might get placebo, or because pragmatically we didn't give placebo, they just got standard care, which was supportive care at the time. And so we became the US leading center for the global Remap CAP trial. Remap stands for Randomized Embedded Multifactorial Adaptive Platform. So this trial was completely integrated into the EHRs. We have Cerner and Epic as our 2 main forces for 2 different sections of our health system. And that aligned very closely with our routine clinical care. So what the platform did was it enabled the trial team to evaluate multiple treatment strategies at the same time for the same patient. And it even assessed if interactions occurred between patients with different interventions. And so analytically, what would happen is that this happened continuously. And so patients were randomized in an adaptive response fashion to a domain that they were more likely to experience treatment success with. And because of this Bayesian model and that mentality, that also really helped get patient buy-in, because we told them, like, you're going to get the most likely treatment that will benefit you, but that could in fact be nothing. And we saw that at the end when we were randomizing with hydroxychloroquine, is that almost all patients were randomized to standard care. But we knew that this could not follow a traditional academic model. We had to reach patients where they were and reach them everywhere. And so we broke out of traditional investigational drug services structures. So how we did that is every patient that came in the hospital had an intake form completed. So this is a patient's chart in Cerner as an example. We built this COVID-19 resources tab, and then this form that essentially every provider would fill out for every patient. At the end of this form, there was a question that said, are you interested in learning about experimental therapies? If the patient answered yes, that triggered an email to fire to a central care team. And then that central care team would then start the process of trial enrollment and any other opportunities we provided. If the form had been completed, or if you were not a physician, this is what you were faced with. So you had links to all of our resources, which were all integrated on our InfoNet, and which is an intranet, and then as well as an external internet for resources. So here's what this looks like to walk through this process. So this is the entire Remap process, and it starts again with the prescriber completing this intake form after speaking with the patient. If the patient was not interested in learning more about experimental therapies, they were excluded from speaking with the research team, and they would just receive clinical care. If the patient was interested in learning about experimental therapies, therefore they answered yes, then again, that alert would be sent to a central research coordinator, and the CRC would then screen the patient for inclusion and exclusion criteria for each domain. If they were completely excluded from the trial because they didn't qualify for any of the treatment domains, they would receive routine clinical care. If they were eligible for enrollment, the CRC would contact the patient or their legally authorized representative via a video call or a smartphone call. Now, this is where we really use technology for engagement. And we learned very quickly that not every patient has a smartphone and not every patient knows how to use a smartphone. So we had to get pretty creative. We actually had nursing leadership on every unit of every hospital that would be the go-to contact. If a patient couldn't use a smartphone, that nurse would come in with their smartphone, or some of the attendings would use their smartphones. We got really creative, but all of this consenting was done over video conferencing. Before we went live with the trial, we actually tested this on all of our grandparents and some of our other underserved patients so that we could think about and overcome some of these access issues. A physician on the central research team would then join the call for patient consent. If the patient refused consent, they would receive routine clinical care. And this note would go into their resources tab saying they were ineligible for the trial. So we were very transparent. Everyone on the care team could look and know exactly where the patient was in the phase of the trial. If the patient consented to study participation, they were sent a link electronically to sign a consent form. So this was all done via DocuSign, again, on a smartphone or a tablet. And then from there, they were randomized and enrolled into the trial. After that happened, any provider, if once they were randomized, that opened a chart and placed an order, any order, they would get a pop-up alert to order the medications that the patient was randomized to. So again, this was all very pragmatic, and most of these medications were dispensed from local central pharmacies rather than investigational drug services. Once the patients enrolled, what they were enrolled to and randomized to also appeared on the COVID-19 resources tab. So this was all open label, which is the only way you can really make this happen. And so the study recipe would be here. And again, very transparent for buy-in. And we also wrote a note in the chart, and we had a hotline that patients or providers could call 7 a.m. to 9 p.m. 7 days a week, as well as an email address to answer any questions about the trial. So moving on, how we allocated scarce resources. So this was most prominent with a drug called remdesivir, which was an antiviral medication used for COVID-19. It got emergency use authorization in May of 2020. And when it first was authorized, it was extremely scarce. This was the first shipment we received from the Pennsylvania Department of Health. You can see we got 36 vials for the entire health system, which is only 6 patient treatment courses. And at the time we had 204 patients admitted to the hospital with COVID-19. So how do you even begin to pick which patients should get remdesivir? And the thing I want to point out is that first come, first serve is not the answer, because it inherently disadvantages patients from underserved areas because they are less likely to present to healthcare earlier. And so we knew that wasn't an option. So we met with ethicists and patient representatives. We actually put together a whole team of ethicists, community members, legal scholars, public health, disaster medicine experts, and then diversity and inclusion experts, as well as physicians and pharmacists, to come up with an ethical standard. All of this information was housed on our intranet. This is how it was displayed. And we had everything about the allocation system. I did hours of virtual training sessions with all local representatives on how to screen patients for inclusion, et cetera. Our model policy for ethical allocation is publicly available. You can find this on Pitt's website. But what the main principles here are one, we wanted to safeguard public health by allocating these scarce resources in a way that maximized the benefit of these resources to the community. Number two, we wanted to lessen the impact of the social inequities of COVID-19 and the outcomes in our disadvantaged communities. And so we ensured by the way that we use technology to screen every patient, that no patient was refused access to care based on age, disability, religion, race, ethnicity, national origin, immigration status, gender identity, sexual orientation, or their perceived quality of life. And then finally, our third guiding principle was that we wanted to ensure that all patients received individualized assessment by a clinician based on the best available objective medical evidence to be entered into the allocation system. So what happened is every single day we got a report of every patient admitted to every hospital. This was then sent to local teams via Microsoft Teams. So we used a team sharing platform to divide out patient lists. Local teams would then screen their patients and talk to local providers, and then all eligible patients for the drug based on clinical criteria would be entered via a Microsoft form into the lottery. Patients who were essential workers or patients who came from a high area of deprivation index score area, which would be an underserved or a disadvantaged area, they were given increased odds of being allocated medication. And then patients who had a poor end of life prognosis were given decreased odds. Importantly, they were still given a chance. So it's inappropriate to completely exclude these patients, but it is appropriate to decrease their odds of allocation based on the overall benefit to public health. And then we would run the lottery based on our weekly allotment of drug and our weekly expectation of patients admitted. Again, not first come, first serve. And then patients who were allocated medication would be communicated with by the central team to local teams. Here's just examples of our information. And I only show this just to show like how extensive these documents were, all electronic, all linked, and all accessible at all times. And then last but not least, I have to give credit to Dr. Taylor Lincoln. She specializes in palliative care training to improve end-of-life care for critically ill patients. And her work promotes high quality communication, which is aimed to ensure that patients are receiving care consistent with their value system. And so we created these documents to guide providers on how to communicate with patients and their families if they were or were not allocated medications and how to handle emotional responses. And then last but not least, our monoclonal antibody system. And I know I'm coming up on time, so I'll go through this quite quickly. But this is the map of Pennsylvania based on area of deprivation index score. The dark red is a 10, which is the most underserved area. The dark blue is a 1, which is the least underserved area. You can see that UPMC's representation is largely Western Pennsylvania, which is a lot of red. So we have a lot of underserved patients. This is where we built monoclonal antibody systems. So if you superimpose that on that map, we basically have a clinic in almost every dark red area. We built over 45 monoclonal antibody infusion systems. And the reason we invested in this is because we believed in the early data that if you give these to patients, it would decrease their likelihood of hospitalization and death. Of course, if you did not buy into that data early on, this is not something you would have invested in, but we thought these were very promising therapies and that panned out to be true based on our own internal data. So this was a worthwhile investment. But your patients that need these therapies are in these underserved areas. So we had to go to them. We invested an unbelievable amount of FTE and time into patient outreach. And so we said we would treat every patient regardless of provider. We waived all patient responsibility for these therapies. The drug is actually free because it's donated by the government, but we don't charge for the test. We don't charge for the infusion. This is upmc.com, so it's an external website. Anyone can go and download this paper referral form and fax it to our central care team, and we can get patients scheduled regardless of where they come from. This is very high level, how many different aspects go into this care team because it is inpatient and outpatient. So we have everyone from design, communications, marketing, legal, staff support, pharmacy, operations, etc. These are some examples of materials we made. So this is a card that we put in our testing centers. So every patient that came in with a test went home with this card. And so if they tested positive, they could then call themselves. We established a hotline that we staffed 9 to 9, 7 days a week. The patient could refer themselves without a PCP. Again, you need to do these kinds of things for patients that don't access healthcare, don't have health insurance, might not have a primary care provider. So the self-referral hotline was essential. These are materials we developed in Spanish and other languages. And then finally, these are data to support that if you invest in this outreach, you make a difference. So when this started, the proportion of patients who tested positive and were eligible for monoclonal antibodies to receiving treatment was a ratio of about 1 to 100. After our outreach efforts, that came to 25 to 100. So the program grew tremendously in ensuring that eligible patients got treated. The other thing that happened is the proportion of patients who tested positive that ultimately got treated amongst white patients and Black patients, there was a big disparity at the beginning. And after our outreach efforts, we were able to close that gap such that the likelihood of treatment was equal after all of these operational builds went into place. The last thing we did was patient testimonial cards. So patients that received therapy that then felt better, that were willing to talk about it. We developed these kinds of cards and distributed them. We did radio, we did other kinds of marketing and communications, really because we believed that patients that got these therapies had less likelihood of dying. And so we thought it was extremely important that they knew about this and would access care as soon as possible. So these are examples of some patient testimonials. And last but not least, I'm coming up on time. I talked really fast over 3 huge systems. So I know we're hanging around for questions. And thank you for the opportunity. And also, I just need to acknowledge the literal hundreds and hundreds of people that I work with every day across a very massive health system in all aspects of direct patient care, all the way down to, you know, people who build the data reports. And so I couldn't do it without them. I can't name them all by name, but it really does take a village. So thank you.
As Joey said, I'm Ivey Wholfeld, and I'm a program manager for the Engage Norris team at PCORI. And today I'll be sharing a bit about PCORI. I'm going to go over what we mean by engagement. I'll talk about the Engage Norris program that I work on, and then I'll share about how PCORI engagement awardees are addressing the pandemic and some of their virtual engagement tips. So now a bit about PCORI. As we know, traditional health research, for all of the remarkable advances it produces, it hasn't been able to answer many of the questions that clinicians and patients face daily. And so the Patient-Centered Outcomes Research Institute, or PCORI, was authorized by Congress in 2010 to close that gap. And we were recently reauthorized for another 10 years in 2019. PCORI has a 21-member board of governors representing the entire healthcare community. Our mandate is to improve the quality and relevance of evidence available to help patients, caregivers, clinicians, employers, insurers, and policymakers to make better informed healthcare decisions. PCORI funds comparative clinical effectiveness research, or CER, and that engages patients, caregivers, and other stakeholders throughout the entire research process. We focus on answering questions most important to patients and those who care for them, and we aim to produce evidence that can be easily applied to real-world settings. So this slide just shares all of the many stakeholders that we involve in our work at PCORI. So what is engagement in research? It's stakeholders meaningfully involved throughout the entire research process, from planning a study to conducting a study through disseminating the study results. And PCORI has 4 engagement principles which guide stakeholder engagement process. There are reciprocal relationships, co-learning, partnerships, transparency, honesty, and trust. And so let's talk about how we engage. And there are a variety of ways and approaches to engage stakeholder partners in research. Stakeholders can serve on an ad hoc work group to help prioritize research questions or develop dissemination strategies, or they could have more sustained involvement in a project, providing input and guidance by serving on an advisory council or committee, or they can serve as a co-investigator or page or project partner. And much like the approaches, there's variability with respect to the level or intensity to which partners are engaged. And this image, it shows how stakeholders are involved in every step of the way, in the beginning stages, from relationship building and skill building, all the way through sharing and encouraging the uptake of findings. And meaningful engagement throughout the entire research process is what makes PCOR and PCORI so different. So, as you've heard by now, engagement is integral to our work and the work that PCORI funds. And so the Engagement Awards program was designed specifically and intentionally to foster engagement and build the capacity for stakeholders to be able to participate as partners in PCOR and CER, and to serve as channels to disseminate PCORI-funded study results. You'll note that the Engagement Awards provides funding to support engagement in and with research. We don't fund the actual conduct of research. And since our program launched in 2014, we've awarded about $112 million to support 546 projects. And as seen by this map, we're building a large national network of stakeholders participating in PCOR and CER. So last year, we introduced 2 funding announcements to address COVID-19, an enhancement to existing PCORI-funded engagement awards, and a special cycle to support engagement in and dissemination of PCOR and CER in the context of COVID-19. The enhancements were required to do one of the following: use an existing engagement awards project infrastructure to build capacity to conduct engagement in PCOR and CER through alternative mechanisms in a time of social distancing and isolation, or enhance an engagement award project's effort to increase patient and stakeholder communities' understanding of PCOR and CER around COVID-19, or leverage existing engagement infrastructure to expand upon the aims and objectives to be specifically responsive to the COVID-19 pandemic. And for the special cycle, projects had to propose that they could help communities increase their capacity to participate in all phases of PCOR and CER while responding to contextual changes as a result of the COVID-19 pandemic. So these projects focused on identifying and using effective methods for engagement to build knowledge, competencies, and abilities for their community to be meaningful partners in research, but in a virtual environment. So 44% of the enhancement awards are using at least one or more virtual tool, and 88% of the special cycle awards are using one or more virtual tool. Most are using some form of virtual meetings like conference calls, webinars, and workshops. And many are using tools to address accessibility for virtual collaboration, or are looking to figure out how to engage virtually with a specific population. On this slide, I'm going to share some key takeaways from our awardees on how to engage virtually. A lot of groups are using social media not only to promote and share their project, but they're using it to keep in touch. So like apps like WhatsApp, they're having group text chains and individual check-ins, and it's creating those channels for feedback and promoting that ongoing engagement in between meetings. And even though we're not meeting in person, we're still able to share a meal and break bread virtually. And so folks are using apps like Grubhub and DoorDash, or they're working with a local restaurant to deliver healthy or not so healthy meals to share while they're having the meeting. I've heard of early morning meetings even having coffee delivered. Sending a care package, like a virtual swag bag with meeting materials, or even sending like quiet time toys to replace on-site babysitters have also been used. Being very flexible, especially with scheduling and access. And so with regards to scheduling, folks are hosting meetings at night and on the weekends. I know Joey was having to do this himself. Or they're breaking up an all-day in-person meeting into a series of shorter virtual meetings. And instead of large focus groups, people are having to do one-on-one individual interviews. Also to address access, I know folks instead are conducting surveys over the phone or sending them in the mail. They're mailing or they're dropping off slides and meeting materials for those who might be calling into a meeting and may not be, participating on Zoom on the camera. Awardees are organizing virtual talent shows and other performances to have that informal fun that you would have, at an in-person meeting. And they're using diverse platforms. So a multimodal approach using screen sharing and whiteboards, chats and polls, breakout rooms, all of these allow for participants to be engaged in different ways that are, let them feel comfortable to share their ideas and feel like they're being heard. And it's important to have champions on each project team who are responsible for checking in with individuals to make sure that everyone is feeling like they're heard and there's opportunities for that ongoing feedback. This slide highlights a project in Baltimore that's engaging a cohort of 20 community partners who reported a low level of digital literacy, and they're working to increase their skills and abilities to participate as meaningful partners in research in a virtual environment. And this project is collaborating with some unique stakeholders, including the Mayor's Office of Digital Equity, as well as Comcast. Here's my contact information. So thanks, everyone.
Thanks everyone for those great presentations to kind of get us started, and also all of our presenters, giving little 15-minute spiels is a lot tougher when we've had so much go on over the pandemic. So thank you all for kind of focusing on a couple of major things that you could present and get the conversation rolling. So again, we've got several questions that are popping in, and a few that we had collected prior to getting started. So, one of the first things I just want to ask, I guess, and again, no particular order in terms of how we tackle it. When we started the pandemic, many of us probably were used to doing conference calls, maybe not so much as many video calls. I don't know how many folks were familiar with that before, but we all at once in March of 2020, it just got dropped right on us, and we went to virtual, and then folks were at home. People who were able to still work from home were having to log in and do their same meetings, but now having kids in the background, pets in the background, what have you. What have been the ways that you all have been able to manage the interruptions or make it so that your audience or your team could stay engaged if you had a 30-minute or even an hour meeting? So any advice you had in terms of just managing those challenges for parents of children and puppies or kittens or whatever that you need that whoever's distracting you.
Sure, I'll take that first because I just adopted a golden retriever who's 14 weeks old. So I don't have human children, but I have a newfound child and I've been learning how to handle this because it's hard. And so I don't know that I have really good advice, just that I empathize and I feel this on every level. I also, in the past 2 weeks, I live in Pittsburgh, Pennsylvania, and there's been a lot of storms. So I lost power for like 5 days. So when you're working from home and have no internet, that is quite challenging as well. So that was eye-opening for our patients that don't have as reliable internet access and things like that, and how you have to pivot and make things work. The only thing I've done consciously since adopting a dog is that I used to work 6 a.m. to 7 p.m. essentially straight. And I think in a virtual world now, we realized you can schedule meetings 10 to 11, 11 to 12, 12 to 1. And you are always sitting in the same chair. You don't have to travel. And so, everything's just back to back to back to back. And we did that for a really long time, and it's exhausting and it's not sustainable. And so we've made conscious efforts. I don't schedule anything more than 2 hours now. And so even if my 3 to 4 is free, if I have meetings 1 to 3, like I don't schedule at 3 to 4, I maybe at 3:30 to 4, but I give myself some time for that, for taking care of children or whatnot. And the other thing I think we need to do as a society is normalize having our children on camera. We're all working from home. We all have stuff in our lives. we're all humans. I don't understand why in America it's like blasphemous if your child appears on camera. That is so not the case in other countries, particularly Europe and whatever. And if you want to be holding your son or daughter while you're in a meeting, I don't see anything wrong with that. And so I think we need to be a little more gracious, quite frankly, in that regard. The other thing we're trying to do, now we're fully vaccinated and getting back to some in-person meetings. And so you start to factor in travel time. And so I feel like schedules are a little more flexible. But like last summer, we were trying to have meetings like in parks, like trying to meet outdoors, trying to, set up areas where you could meet at the park and let your kids play for an hour while you're sitting at the picnic table talking and brainstorming if you don't really need a computer or whatnot for that meeting. So we got pretty creative with some of that to try to help my colleagues who do have children.
Right.
Not every meeting needs to be a Zoom meeting, and so deciding what rises to that level, and also I think making the agenda and the asks and the goals of the meeting very clear up front, so that way we can hop right to it, especially if there's a lot of things going on. So.
And the other thing I would add too, first of all, as an organization, it wasn't that difficult of a transition for us because we had some remote employees anyway. So we were already on the Zoom bandwagon before people were doing it. But the other thing that is exciting for us as the disability community is I think it's showing businesses just how easy it is to make this transition if you really want to. And for years, we've had a segment of our population has been told, oh, sorry, you can't do this job remotely. You've got to be in an office. And it doesn't work for some folks with disabilities. And as a result, it was a barrier to employment. And I think that this has shown companies that you don't need to do this. You can do it in a remote fashion, and people can be just as productive and effective members of the group in the virtual world.
Oh, that's awesome. Yeah, that's a great segue. Well, through that, maybe what has been your favorite use of technology? Any of you all have a particular, and again, not like we're endorsing any publicly traded company or anything, but any innovative use of technology that you just certainly weren't thinking about pre-pandemic? You're like, oh, wow, we definitely need to just do this more.
I will say, even outside of professional space, like the fact that you can have a Zoom video meeting, this technology is not necessarily new, but we never did. When I had calls with people not in my building before, I would just call them on the phone. And, we started doing Zoom meetings and video, and it's really nice to connect with your colleagues all across the country and even your friends. For example, in my residency, I trained, there were 7 of us in my class. And in the pandemic, we started having, 7 to 9 p.m. on a Tuesday, like all my co-residents hung out on Zoom and we talked and we caught up on life. I was like, we could have done this outside of the pandemic, but we never really did. And so that was really interesting to connect with people like that. And I hope I don't lose that now that we all go back to normal, so to speak. The other, random, I think scanning QR codes to have menus at restaurants makes all the sense in the world. I don't know why, I hope we never print menus again. And so things like that, are silver linings of the pandemic. I think, just like to Karl's point, we were like, we could have been doing this all along. Why weren't we? Absolutely, people can work from home, and you don't need to kill the planet and things like that. So those have been some nice technology additions.
Awesome. Others?
Now, just echoing the same thing. It's realize where you could use it in the social setting and the like, and having virtual happy hours. We've done that as an organization has also been nice. So it gives you the opportunity to have a time to speak. And we have a weekly team meeting, and that's every Monday morning, and we allow ourselves a little flexibility in that meeting to just talk about how your weekend was and that kind of stuff, just like you would if you were in an office and we're catching up with people. So just allowing your flexibility for some of that stuff to build in so that it's still like an office and you're still building that, doing that team building.
I'm gonna have to say, just using all the different tools in the toolkit when it comes to virtual engagement. And so, some people might not feel comfortable, unmuting their mic and talking, and they'd rather just use the chat or, just participate in polls, or they're more of a breakout room person, to have a smaller group. And so to have all of those available is it's nice.
Oh yeah, Ivy, you just made me think about teaching virtually. I think some of our students actually enjoy chatting in the chat box that would have never raised their hand in class otherwise. So maybe you do engage a different cohort than is used to in that in-person environment. So good call out. Now, Erin mentioned this a little bit earlier when she was talking about patients with smartphones or not having smartphones and the way they kind of adapted to having a nurse help, which I thought was really cool. I did want to ask if others had any comments about financial challenges. So I think one of the things that I immediately started worrying about when the pandemic hit is, just the financial challenges that patients and their caregivers often have related to new technology requirements. Like I said, maybe if your internet wasn't up to date or whatever it was. So can any of you speak to that in terms of like what again, I think Erin talked about it a little bit, but other topics in terms of like how we responded to some of these financial challenges and how we can overcome them.
I know that we were seeing a lot of applicants factoring in, including devices and like iPads and other different tablets and accessibility for folks to have internet access at home. And I think that it's great that they're including that into the compensation that they're thinking about. But we're also wondering, like that long-term sustainability is, well, are they going to be able to use this for participating in other projects? Is it going to be taken away at the end of the project period? City living, sorry.
I'll say two things. One, I think taking kids out of school is something we're going to regret for a really long time as a society. And I think that we should have poured time, energy, and resources into figuring out how to safely get kids in school as opposed to like playing football. And so because these kids will never get that time back. And there are kids that had no internet or share a house with 7 other learners in 5 grades who don't have a parent who can help them through different things. And so I think that's something that our society is going to feel the pain of for quite some time. And I wish I had these were financial challenges we recognized in our key patients and our key people that we're responsible for as a society. And this is how we fixed it. I actually think that's like one of our biggest failures as a society this past year. Related to COVID care, I will say for monoclonal antibodies, patients that didn't have transportation or patients that had no access or healthcare or financial constraints, we did the 2 things I already talked about in that we made a patient direct hotline so they could refer themselves. So that cut down, the need for care visits or whatnot. And then we waived financial responsibility for everything related to MAB. The health system decided to take that because it kept patients out of the hospital. The last thing we did is we partnered with a home infusion agency for most of Western Pennsylvania. And so patients that didn't have access to transportation, even though we did pop up so many centers, we would refer them to the home infusion agency. And then the home infusion agency went to their house to give them the monoclonal antibody infusion at home. So we only did that for patients with transportation concerns, but that was another way we tried to overcome that.
All right, and so we're getting a few questions, I should say, in the Q&A box. One specific questions for one of Erin's studies. It looks at the monoclonal antibody results. Basically, say they were very impressive, and was curious if this project if this project design is now being used to promote health equity in other areas now.
Yes, I can't specifically speak to other outreach areas, but this Remap platform and the care team that we built for monoclonal antibodies, we're absolutely like using that infrastructure to think about how we provide care in other aspects. I will say one of the big areas we're going to approach next is diabetes, both inpatient and outpatient, screening, treatment, maintenance, patient communication, et cetera. So that model will be repurposed, but more to come on that.
Awesome. Thank you for sharing that. One of the questions in the Q&A box I want to save towards the end. I think this is a great question. Might be good to kind of wrap up on as well. One thing I wanted to touch on, and this may be, it's for those of you who haven't been as engaged with research through PCORI or the Patient-Centered Outcomes Research Institute. I don't know so some of us focus maybe more in the NIH world or AHRQ. So sometimes researchers aren't as familiar with some of the funding that's offered through PCORI, but it's been around now for over 10 years as it was reauthorized in 2019 to 2020. So during the reauthorization, one of the things that I thought was really interesting is that research for individuals with intellectual or developmental disabilities, or IDD, was identified as a specific research priority. And so with that, I mean, I might start with Karl and then maybe hear from Ivey and Erin as well. Like, you know, when I see this, that's awesome. That's great. I feel like, okay, we're going to have this as a specific priority. And Karl gave a lot of really good advice about just in terms of engagement, best practices or whatever. So rather than maybe the best advice for the engagement or remote methods, maybe we could talk about, so Karl, I can imagine a lot of folks in your community that are engaged in your organization as well, starting to get a lot of phone calls from researchers. So we have a lot of researchers on the call today that might say, hey, this is a great priority to work on. Maybe they hadn't thought about working with a group like AAHD before. Any advice on how researchers can just get started with you know, approaching a patient advocacy organization like yourself, or working directly with patients so that they can have real authentic engagement versus sort of an afterthought, like, hey, we're doing a research program and you're invited kind of thing?
Yeah, it's really about being purposeful about it and thinking about it ahead of time. And that also includes then the extra things that are going to go into getting your IRB approval for intellectual disability, because that is going to be another major factor. And that's unfortunately one of the reasons why that population is left out so much, because usually you've got to use, you know, a proxy consent for the individual if they can't give it themselves. And it does make it more challenging, but the folks that have intellectual disabilities have unique health needs that do, you know, play into all this. And I think it's important that we do engage that community, but it's got to be done, like I said, in a purposeful way that's done. And like you said, I think the best way to do it is probably reach out to the organizations that work with those organizations. The ARC is the national organization that really focuses on intellectual disability. They have chapters all across the country. And you know, they're ones that really work with that population. We've done work with the ARC national office in the past. So that would be one of the places I would think to start if you really want to engage that community. And really just try and look at, you know, how you can, what's the best way, and one of the best ways is to go to that community and say, how can we engage you on this, and be open and be flexible to what they say.
I love that. I love it. You know, sometimes just starting out in the beginning and just saying, you know, kind of coming in with that kind of open mind and just asking. I was going to ask what, and you've probably seen the good and the bad, and hopefully this project doesn't fall into that bad category. What are some thoughts that you've, you know, based on some of the things you've seen and what you're probably going to start seeing in the IDD space? Any advice for some of the researchers on the call in terms of writing that first engagement award, or thinking through that in a way that's authentic and that works with the community in a good way?
Yeah, something you said, thinking about an open mind. And I think, you know, successful patient engagement is going to think about, you know, what's the areas of importance for these populations, and what's going to affect them in their day-to-day life and their quality of life. And that might be at odds with what researchers' areas of importance are for these populations. And so to be successful in addressing that, I think it's that long-term relationship building, and, you know, starting early. It's not going to be, oh, the deadline for this proposal is in a month, so let's hit the road. Like, we need to, you know, have these early conversations to build that successful relationship.
Oh, I like that. And Erin, I know because you all knowing that you were gonna, you know, you knowing that health equity was going to be a challenge, and see that same kind of thing happens, I think, in the space with underserved populations, minority communities. Sometimes at the very end, a researcher goes to a minority population and in a sense becomes like tokenistic, or it doesn't feel like you really wanted to engage the group. You were just adding them in to like make your grant proposal look better or whatever that was. So Erin, I felt like when we talked to you all really, you know, went at it from an authentic way and said, look, we need to have input, you know, from very different members of the community, and hear any thoughts on just how that experience went, or how it was received, both from your hospital system, but then just what was that like?
Yeah, thank you for a very excellent question. That's something we all deal with every day. So it's very real. It's very true, right? I think a couple things. We have to recognize that patients from underserved communities and underrepresented minorities have every right in their world to distrust everyone in healthcare, because in many ways we have failed them over many times. And so that's step one, is like, you have to appreciate and acknowledge that they can absolutely distrust us, and that is in fact probably okay. So representation matters. I mean, so we tried as hard as possible to have as much of a diverse group of leaders amongst all of these care teams as possible, to get input from patients and from different representation. Just not even, the color of your skin or the gender you identify with, but where you're from. So we tried to have, you can't do system level work unless you have representatives from every single hospital on your team. So we made sure that there was a voice from every care community to represent those patients. We met one-on-one with individuals from minority populations about either getting vaccinated or getting treatment, and then asked if they were willing to go speak to people from their communities. We went to the communities, and I know everyone did this with vaccination efforts, but you have to go to the patients, just like going to their homes or whatnot. And then the other thing we were really, really, really cognizant of, especially with monoclonal antibodies, you cannot outreach to these patients about treatment if you do not message it with a vaccine. And so if you don't come with all the treatment systems you've built with also telling them how to get vaccinated and how to explain, even if you've had disease, you should still get vaccinated, and really focus on the prevention aspect first, and then talk to them about treatment options, that's the wrong message. So a lot of our monoclonal antibody work was paired very closely with our vaccine events and our vaccine communities. So all of those things. The other thing I'll say also too, just from being a woman standpoint, is like women representation is another thing we don't think about a lot. And honestly, I didn't really think about it, but I started doing this work just because it was in my field, and started doing some media and things like that. And, after the first kind of press conference I got over 40 emails from women across, the state, the health system, just saying like, good job. Like, no one directly was like, thanks for being a woman, but it was like, you could just tell that representation mattered to them. And it was like cool to see that. And I didn't fully appreciate how much that mattered. And so I think, just all of us being a little more aware and upping our game in that aspect of knowing how much this impacts everyone around us is important too.
Yeah, I love that comment. Again, just representation in general, as people see, folks they can identify with, and I think it's very valuable. And just being purposeful about that, and trying to be inclusive. One of the things that has always, or has definitely come up, I think, as well, especially when we're talking about delivering healthcare, as well as in research, when we're trying, again, Karl mentioned IRB. Challenges related to privacy, right? I'm very fortunate. I feel like my wife and I have a little row home in the city in Baltimore, and it's just the two of us, and we kind of coordinate when either one of us are in and out. And obviously, I'm kind of loud, so she doesn't like to be on a call when I'm on a call at the same time in the same house. So we try to coordinate, like, when who's teaching live or whatever, and the other person can go to the gym or go do something else. But we can't say that's the same for everyone in terms of challenges to privacy. Maybe you're in an apartment and you've got 2 or 3 roommates. Maybe it's something where in the clinical setting, we think about going, that private visit with our physician or our nurse practitioner, and we want that, we want to be able to share openly. Maybe not even, again, just creating that safe space for the patient. What challenges throughout the pandemic have you all encountered, at least hearing from either your groups or what, and what was the best way to tackle that, or any idea, any thoughts on how you all were able to manage around that? I don't know if we want to start with Erin too. I don't know if you had some thoughts from a clinical perspective. We kind of go around as well in terms of how we manage the being respectful of folks' privacy.
Yeah, I can. So when COVID started and we had to shift out of our offices and like get 6 feet and whatever was going on, I didn't have an office until like October of 2020. So there was a solid 6 months that I would literally just have to bounce around to different people's places to find a camera and a microphone to have a meeting. And I do telestewardship with patients. So I call community hospitals all day and review their patients and make recommendations. And so I was doing this like in the hallway on my laptop, and finally I was like, this is so bad because there's patient conversations going on. So I don't have a good answer. I eventually got an office. I do share this office with another person, but I think this is just something we all really struggled with. Noise canceling headsets are good, but the space issue was problematic. But again, just allowing people to work from home, I think, solved some of that.
And Karl, you mentioned a little bit too, some of the patients in your community already rely on proxies or have other challenges like that, but any other things that came up where just privacy was an issue? And I don't know if maybe you'd hear through members of the organization, or just if it came up a lot.
Yeah, I mean, privacy is always a concern when it comes to disability, and depending on what kind of disability it is, it does change things, especially when there's a question of whether people disclose their disability or not to disclose their disability in certain circumstances. So privacy is always a concern. I don't know that there's anything that was specifically different about this particular pandemic that would change that. I think that the one thing that we were talking earlier about, just the challenges of working in the digital world, and I think that one of the things that we sort of realized, and we referenced this a little bit earlier, but just how much this particular pandemic highlighted the digital divide and how it's just not available to some people, or how it even became problematic. I mean, you guys were mentioning yourselves about where we do things from, the fact that we have to deal with a spouse that's maybe doing things at the same time. The fact that, that's one of the reasons I haven't been I'm actually at AAHD's office today. That is a rare thing for me, but that's because my wife's got things all afternoon on Zoom. And while, our offices are far enough apart, we find that when we're both on Zoom at the same time, the bandwidth sometimes becomes an issue. So it's one of those things that you just sort of had to learn how to juggle some of those things. So I don't know if it's privacy, like I said, always an issue with the disability community, but I don't know that anything was unique to this particular thing that was made aware to us.
Gotcha. Ivy, yeah, go ahead.
Yeah, I was gonna say something no one's brought up is, thinking about password protection, private Zoom meetings, invite-only Facebook groups, using encryption. Like, I think that this is a lot of sensitive information. We're talking about, how we're having these conversations, verbally, but also, thinking about it, in that virtual space as well. And so, having to think about that and factor that into meeting planning.
That's a great comment. I was terrified of someone Zoom bombing my class. So I was when I heard of that early on, I was like, wait a second. So I do not want to be in the middle of talking about pharmacy management and leadership or something, and all of a sudden have some random person drop in. So that's a great comment. Might shift gears to one of the institutionalized settings that has been near and dear to my heart as a pharmacist, as well as our nursing homes. Our nursing homes were hit really hard by the pandemic for a variety of reasons, really highlighting the importance of research and just improvements in the way we deliver care for these vulnerable patients. So, and again, knowing that we're talking about infectious disease research in the future, how can we, how do we engage patients, family members impacted by nursing homes, or even nursing home staff moving forward? Obviously, some nursing homes have a lot of trouble maintaining adequate staff, and I'd imagine in some facilities it's even difficult to say, I've got, I don't have time to be participating in this research proposal because I'm already working, overtime and covering double shifts, and so any thoughts or comments on what we should be thinking about going forward, particularly for this, again, I'd say quite vulnerable population, especially if future pandemics or other things like that? How can we bring them into the fold?
As the disability advocate, I've got to speak up right away on this, and that has to do more with the fact that this might not be the direct answer to the question that you're looking for, but it's going to be the answer that I want to give. And that is that if anything, I think the COVID pandemic, and one of the drums we've been beating throughout this entire thing, is it really underscores the need for more funding for home and community-based services, so that people are not in institutional settings. Because there's a lot of folks out there that could be cared for in a home setting, that it would reduce the risk of these types of things happening, so that we're not having the major issues that happen when COVID gets into a nursing home, and it just really ends up affecting everyone in there, and it puts people with disabilities at a higher risk for that reason. So yesterday was the anniversary of the Olmstead decision. If you're not familiar with the Olmstead decision was a Supreme Court decision that basically said that people with disabilities have the right to, under the ADA, to get care in the least restrictive setting. And that means, in a home and community-based setting. And there's been a lot done in Medicaid over the years to try and provide more funding to states to be able to do that. But as an organization, we've always been an advocate for increasing that even more, because Medicaid just does have that institutional bias set into it. In terms of how it's dealt with when it's there, I think the other thing that's been hard for the disability community is when you had COVID go into a nursing home, lots of times what ended up happening was you had people with disabilities cut off from their family if they were in the nursing home, because the family members weren't allowed to visit. And it really created a lot of, it became very problematic for that population, because those family members were their advocates. And especially if the person had an intellectual disability, they couldn't advocate for themselves. They didn't understand what was going on. And if the family member's not there to advocate for them, it really becomes problematic. And that's the thing that I think we really need to look at systematically, is how do we make those changes so that stuff like that does not happen again.
No, I love that. Thank you, Karl.
Thanks, Karl. That was really, I agree with a lot of that. I will say from the clinical trial standpoint, I guess, is where I'm coming from, in that these patients are traditionally excluded from clinical trials because of the principles of informed consent. Dementia and other baseline intellectual disabilities, for example, are excluded, and then other kinds of disabilities can often be on the list of exclusions. We fought for almost 6 months with our IRB to remove all of those exclusions, with basically all these principles in mind, and that this is open, pragmatic. We're in a pandemic type setting, and these patients are patients, and they also have this terrible disease. We need to learn how to treat them too. We need to maintain informed consent. We need to have these conversations with family members or other patient advocates or representatives for these patients if they truly cannot make a decision for themselves. But just having dementia or any other of these countless conditions shouldn't just write you off from being able to be enrolled in these trials. But that did take a lot of time and a lot of effort. We finally were able to do it. But in the beginning of the pandemic, we unfortunately had to exclude a lot of those patients. And so I think just really evaluating like systems that are in place and asking, is this really still the best system? Is our status quo appropriate? And do we need to adjust? Because I don't see any reason that dementia should be an automatic exclusion from a trial, and countless other examples. And then with monoclonal antibody therapy, we worked closely with our senior communities. They actually, I didn't include that on the map, but they all were infusion centers. So all of our senior communities use Epic. And so representatives at every senior community care center would screen every resident every day if they had COVID positives. And then they would self-submit those patients for treatment. And we worked with their drug purchasing organization to be able to get MAB supply from UPMC Central Pharmacy. And we'd ship drug directly to the senior community care provider pharmacies. And then they would just treat their own patients, so they wouldn't have to transport them to infusion centers. They could just treat them right there. So I think, and they taught us a lot about their workflows, their leadership, their patient populations, et cetera. So just getting them at the table and working with them is important too when you're thinking about these systems.
Great. And Ivy, I didn't know, have you seen any really good, since the pandemic started, any good examples or things we can think about in terms of engaging that institutionalized or that the skilled nursing facility or assisted living facility type groups?
Yeah, I think the most successful projects are engaging all of the stakeholders. And so, as you mentioned, it's not just patients, it's their families and nursing home staff, administrators, everyone who needs to be involved is having a seat at the table.
Now, that's a great comment. For us too, we've been thinking a lot about how we always think about our systems designed around a patient, right? But it's really like there's such a ripple effect in anything that happens to a patient because of, spouses, children, parents, friends. We're all connected, and it's hard to eliminate our social connection. So, considering that, so I love that. This may be a good question for Karl too to follow up a little bit. Is what I was thinking is, and one that came in the chat box was, did the pandemic help activate a lot of patients and caregivers in your community that said, hey, we've got to be louder because of what's happening? Was it one of those things that, because I always wonder what gets someone from being a patient, or, again, because the moment you start advocating, you're sort of outing your whatever your condition is, right? And I know there's like a transition from a patient going from being just a patient to now all of a sudden being ready to be an advocate. And I've worked a lot in the HIV and Hep C community that where there's also often stigma and other things associated with being the patient. So being an advocate, you're already at a point where you're ready to shout from the rooftop. So did this cause a lot of folks to be a little bit more activated because they felt like they needed to speak up?
I think that what it did is just reinforce the need that we need to continue to do it. I think the disability community as a whole has generally been their own self-advocates for years. So we've learned that we have to do that. Unfortunately, so often, when we go into situations, we're entering, the health care industry, and they're viewing the disability through the medical model and not through, the way we would view it as more of a social issue. And how do we overcome barriers? And my disability doesn't need to be cured. My disability needs to have barriers that are overcome. And so that's been something that's just sort of in the disability community. And I've been doing that my entire life, and the rest of us that are in the disability community have been doing that in our entire life. And if anything, like I said, this just reinforced the need for that. Early on, the issue was, making sure that, when you talked about whether ventilators were going to be, how it was going to be determined who got one if you started getting low. And that was a lot of the advocacy that happened early on, is to make sure, hey, listen, just because someone has a disability doesn't mean that they should be on a lower tier in terms of, where they belong, in terms of being able to get a ventilator. Then it became more the shift, like I was just talking about, around, facilities, whether it's a skilled nursing facility or a hospital, and someone's in there and family members can't get in to, visit them. It became an advocate issue from that perspective, and trying to do what they could. I had a very good friend who ended up breaking his leg during, so completely unrelated to COVID, but he's in a wheelchair, and he had broke his leg, which seems odd for a person in a wheelchair, but he had broken his leg and was unable, and his wife was unable to get in to visit him. And even though, he's been a self-advocate his whole life, when you're on heavy pain medication and all that kind of stuff, sometimes it's hard to express exactly what it is you're looking for and experiencing. And as a result, his power wheelchair almost got lost because his wife wasn't there to, advocate for what was going on. And those are the kind of things that sort of reinforce for the disability community. Yeah, this is something that we're going to continue to have to do. It's never going to be something we're going to solve. It's never going to be a problem that's going to go away. It's always going to be something that's unfortunately inherent in the system. I could talk all day about things I could suggest for ways we could address it in the future. But for now, it falls back on us, unfortunately, as the patients, to make sure we're being our best advocates.
All right. So this next question is one that might be, and I think I know the person asking this question, who's been a community advocate for many, many years, and she's taught me a lot about advocating and engaging the community. And she asked, and I hope I'm interpreting it right, what she's getting at, but she really wanted to ask to the panelists, do you feel that you have grown? And I'm guessing in the context of virtual engagement and what you've learned through the pandemic, would you care to talk about maybe how you feel like you've grown as a clinician, researcher, just person through this, in terms of where you think this pandemic's kind of taken you? You might need a second to think about that one, because that one's a little deeper.
I think I can talk specifically about what, I was talking about a lot in my presentation, which is, so often as a disability organization, our main focus has been, over the years around physical accessibility. When we do our technical assistance work, it's around, how you, help, someone set up something in a way that someone in a wheelchair can get around, or whatever it is. This has really helped shed a light for us. We were aware of 508 compliance as it relates to screen readers and all that kind of stuff, but it really, I think, underscored for us the need to up our game in this area. And as a result, as an organization, I think we're better off in that way. for this, because, you know, now that we're doing things virtually, we've got to make sure everything is going to be fully accessible to folks that rely on that kind of technology. So I think that's one of the things that really is, I think, as an organization, really sort of affected and helped us as an organization sort of take our stuff to the next level.
I think as an organization, we grew by being able to be responsive to the pandemic. These funding announcements that we put out last year, we cut the review process from application to letter of award in less than half. And, you know, it takes a village to get that done. You know, there's a lot of people behind the scenes reviewing proposals and, you know, getting everything put together to, you know, to be able to be responsive and let people do this good work. So it was definitely grew as a team working on that.
Yeah, I it's funny, I turned 30 in December of 2019, and I feel like that's my last memory of before the pandemic. And I was thinking about that because now, you know, 2 years later, I'm like, wow, what have the last 2 years been? I think I can't really even, you sent us the questions in advance and I still can't come up with good words to describe this, but I've grown personally, professionally, and really it's just been that, I mean, it was the worst 18 months or so of, I hope, all of our lives in terms of how, you know, this pandemic was horrible in so many ways, but in building these systems and in working with people I would have never worked with across even stuff like this, across all sectors of the healthcare field, you know, I think we were really siloed before in our job and our role, and we tried to make an impact in pharmacy. And, you know, healthcare is really segregated, and that's something I think we really need to work on. And this did break down some of those barriers. And kind of to Ivey's point, all of a sudden, you know, they used to tell me it took a year to update an order set. And now, you know, magically they can get done overnight. And granted, you know, everyone was working 20 hours a day, which we don't want that. But it does seem like we can do things more efficiently, more proactively, more collaboratively, and with more input. And that has been tremendous to see. I'm really in awe of everyone, not only at UPMC, but across the country, across the world, to see how people came together to take care of patients in this time. And I'm definitely a better pharmacist and team member and leader and all of it because of it. I might be a worse like daughter, like I haven't talked to my parents in a while. But other than that, you know, because you can't do it all. And I think a lot of us made personal sacrifices to invest in our patients in the past year and a half. But no, I think I've grown more than I can say.
Yeah, and to add, I think that you're talking about teaching at the University of Maryland. It's definitely forced me. I used to be one of class starts right on time, and I taught that way for a very specific reason because I teach operations, and when we start an operation, you want to have a good start and a good close and those kind of concepts. But with the pandemic, having a little, I think one of you mentioned earlier, just having a little bit more grace, maybe having a little bit more empathy, and not treating that start time as you might do, you know, forcing me as a teacher to make sure there's a little bit of wiggle room, you know, for whatever it might be, internet connection, switching from Zoom, you know, meeting to meeting. So having a little bit more grace with our colleagues and our students and our patients is a great way to think about. And yeah, I think we've all had to sort of figure out how to be flexible with one another, which hopefully will carry we go post pandemic. We don't forget all of this stuff, right? We don't go right back to it. So the last thing we'll end on before we, and if we have a minute or two, so our at 12:45 we'll have Dr. Gerald and Senator Van Hollen on. And so before we get to that, guess what we can end with, and this is sort of thinking forward. So, you know, I guess there's probably things we love about being in person and being next to one another and shaking hands and that sort of thing, and just being physically present. But do you think that virtual engagement can be as effective or more effective in some cases as that in-person engagement for things like patient-centered advisory boards or for conferences like this or whatever it might be? So, and again, you can would love to hear your thoughts and a quick why or why not, and then we'll wrap up.
I would say it could be more effective for no other reason than you can engage more people that maybe you wouldn't have been able to engage. You know, we talk about our community. One of the things we had done this past year, we did a listening session for people with spinal cord injuries on another project. And it was so much easier to do it virtually because they didn't have to worry about transportation and getting there and all that kind of stuff that becomes issues for that particular population. And, you just send them the Zoom link, they were able to get on and you could have a really good conversation with them. So I think it really opens the doors to a lot of populations that maybe would have been harder to engage with when you're doing it.
I think it's a more is more approach when it comes to virtual engagement. So, being on a variety of different platforms, using it frequently over a long period of time. Obviously today is a really fun way for us all to be together, but having that sustained relationship building over the the course of the project when people are working together. And of course, as I mentioned earlier, using all those different tools to enable participants to feel like their voices are heard. And then I think adding on to what Karl just said, I think we can look to, communities that are already really, strongly engaging virtually because of, they're spread across the country or the world. So I think about the rare disease community, that's another groups who were, very strong with virtual engagement because they were not able to always meet in person.
I'll just quickly co-sign that in that it's refreshing and rewarding to see how many people have joined virtual conferences that never had the opportunity to engage before, whether that be they're not supported to travel, they don't have personal finances to do so, they're from different countries, they can't travel, whatever. So I think it really broke down a lot of barriers and expanded access, which is awesome because having all those voices is really important. On the flip though, I will say that it is not the same. And I think while engagement at the patient level or in smaller meetings has really been valuable, having large scale virtual conferences, at least for me, has been less engaging because you don't get that separation from your work environment. Even consciously talking to my boss before a big infectious diseases conference in 2020, I was like, I'm off Wednesday through Friday because I'm attending this conference. I just ended up working because I'm sitting at my computer and it's hard to invest in yourself and your own learning when you have patients and when you have other stuff going on because you're sitting at the hospital. So I naturally got sucked into, all of that rather than just sitting and watching lectures and being engaged. So I think there's, two sides to it.
All right. With that, I want to let's thank our panel for that amazing round of discussion.